Welcome to the increasing importance of identifying urticaria to achieve control opportunities with T2 inflammation targeting agents. This is presented by Global Education Group in collaboration with the Asthma and Allergy Foundation of America at Immunology Live. My name is Professor Luz Fonasher. I'm Professor of Medicine at the Long Island School of Medicine. Today's session is interactive, allowing us to take your questions in real time throughout the presentation. We encourage you to enter the questions at any time in the box below. I would like to introduce my co-presenter, Dr. Marcus Mohr, Professor of Dermatology and Allergy at Charité Universität Medizin in Berlin. Thank you, Marcus, for joining us today, and let's get started. So these are our faculty disclosures, and let's go over the objectives of these sessions. We wanted to summarize the relationship between triggers of chronic inducible urticaria, from henceforth will be called CIndU, and the underlying pathophysiologic pathways. Apply a comprehensive approach to the diagnosis of urticaria, confidently identifying chronic spontaneous urticaria or CSU, CIndU, and chronic inducible cold urticaria or CIndU cold. Optimize the treatment of chronic spontaneous urticaria and CIndU by stepping up treatment with antihistamines as needed based on routine assessment of disease activity, impact, and control, and explain the mechanism of action, the current efficacy and safety data for emergent treatment options targeting type 2 inflammation in relieving burdensome symptoms of antihistamine refractory CSU and CIndU. So as you will see, chronic urticaria is really quite common. There's a worldwide prevalence of 0.7%, and there are differences in the different continents and countries in terms of the prevalence. There's an average age of onset between 25 to 50 years of age. There is significant major impact on the quality of life, including sleep disturbances, sexual dysfunction, depression, and anxiety. CU comes with a very heavy global burden for both the patients and society as well. There are different types of chronic urticaria, and there's the spontaneous appearance of itchy wheals and angioedema, or both, more than 6 weeks due to unknown or known causes. Chronic spontaneous urticaria accounts for about 76% of the chronic urticarias, and CIndU or inducible urticaria accounts for about 24%. So by far, the CSU is still the most common. For physical urticarias, there are those that are triggered by physical factors, such as symptomatic dermographism, cold urticaria, delayed pressure urticaria, solar, heat, and vibratory angioedema. There are also other inducible urticarias, such as the cholinergic urticaria, where active and passive warming is a trigger, contact urticaria, where it's contact with an inducible substance, or aquagenic urticaria, which is water as the trigger. There are obviously other rare and atypical forms of CIndU, such as delayed dermographism, cholinergic dermographism, cold-dependent dermographism, and cold-induced cholinergic reflex urticaria. But by far, they are really very rare. Let's go to our first polling question. How confident are you in your ability to differentiate different forms of chronic urticaria? Extremely confident, very confident, somewhat confident, not very confident, or not at all confident. And let me give you some time to do your answers, and let me go on with our presentation. What are the features of chronic spontaneous urticaria? Interestingly, about 40 to 50% are associated with autoantibodies. 50% have a combination of hives and angioedema. 40% have hives alone, but 10% have angioedema alone. 10% have some systemic complaints. 10 to 20% are aspirin intolerant, and about 40% of chronic spontaneous urticaria last longer than 6 months, with an average of 5 to 7 years. So what are the consequences? If you're having urticaria for 5 to 7 years, what are the consequences of inadequately controlled CSU and CIndU? And in fact, only 1 in 5 patients with chronic urticaria has their disease under control, while 75% have stopped or reduced doing fun things in life. Over 60% reports depression and anxiety. About 50% has a reduction of work performance. About half has impaired sleep. More than half have decreased concentration, and about 40% have relationship with partners that suffer. The healthcare cost is tremendous. Direct and indirect costs, including frequent healthcare visits, work absences, school absences, all are consequences of inadequately controlled CSU and CIndU. There are comorbidities in chronic spontaneous urticaria. So we know that about 40% of chronic spontaneous urticaria have associated inducible urticaria, and they have depression and anxiety, but there are also autoimmune diseases associated with CSU, including Hashimoto's thyroiditis, rheumatoid arthritis, pernicious anemia, vitiligo, diabetes, Graves' disease, and celiac disease. Identification of triggers and measuring disease activity is very important in the diagnosis of chronic inducible urticaria. But in physical urticaria and CSU, we said that about 40% of CSU patients also have physical urticaria, the most common of which are symptomatic dermographism and delayed pressure urticaria. Physical urticaria tends to have longer duration than CSU, and CSU and concomitant inducible urticaria may be less responsive to conventional treatment. All right, we have received the poll that we had earlier, and the most common answer is C, somewhat confident. And at the end of this session, we would hope to think that everybody would be very confident, or at least extremely very confident when we complete these sessions. So how do you grade urticaria? Just like in asthma, you want to look at the urticaria activity, you assess the disease activity, and then on every visit, you want to assess the disease control. So how do you assess urticaria activity scores? Well, the UAS7 is a summation of the control of the activity of the urticaria over a 7-day period. So for every day, you would have an itch score of 1 for mild, 2 for moderate, and 3 for severe. A wheal score, or the number of hives or wheal, at 0 to 20 will be 1, 20 to 50 will be 2, and more than 50 will be 3. You add this, and for a 7-day summation, you have a weekly UAS7 score. And this is the score of 0 to 3 for wheal, 0 to 3 for pruritus for each day, and a 0 will be urticaria-free. 1 is well-controlled, 7 to 15 is mild, 1 to 6 is well-controlled, 7 to 50 is mild, 16 to 27 is moderate, and 26 to 42 is severe urticaria. What about control? So we have the disease activity. How do we decide whether you have a good urticaria control? This is a much easier test to administer in the patient in their everyday follow-up. How much have you suffered from the physical symptoms of urticaria and or swelling? Very much, somewhat, a little, or not at all? How much was your quality of life affected? How often was the treatment enough to control your hives? And overall, how well do you think your urticaria is under control? So when you have a grade of 16, you have a complete disease control, and less than 2 is very poorly controlled disease. Note that the cutoff value of less than 12 have a maximum sum of sensitivity of 90% and a specificity of 71%. What workup do you do for chronic spontaneous urticaria? The basics is really a SED radon or CRP, a differential blood count or a CBC with differential, and an IgE with IgG anti-TPO as the very basic test that you can include in the evaluation of your chronic urticaria. And based on the results of these tests, further testing may be performed as indicated, but note that allergy testing is really almost never needed or useful in chronic urticaria unless the history is really very suggestive. And the common consensus, really, not only in the United States or in Europe, is generally the consensus recommendation favors the performance of a very limited laboratory testing to confirm or rule out an underlying condition, such as infection, autoimmune diseases, or endocrine disorders. History is extremely important in the evaluation of chronic urticaria. What about inducible urticarias? There are many forms of inducible urticarias. The most common is what I will discuss today, and it's symptomatic dermographism, cold urticaria, and cholinergic urticaria. There are provocation tests to diagnose these CIndUs or chronic inducible urticaria. You have to determine the relevant triggers, and sometimes there are more than one triggers that you can see in the patient. And once you determine the triggers, you also want to assess the trigger thresholds. Why do you want to do that? Well, counseling on avoidance of relevant triggers is important. You want to measure your disease activity. You want to monitor whether your treatment is working, and it should be carried out before you start treatment if possible and during therapy. Repeated provocation tests can help optimize the treatment. You want to test the sites that are not affected by urticaria in the last 24 hours because they may be in the refractory period. Also note that individual patients may exhibit two or more CIndUs, and in rare cases, or more concurrent triggers may be needed to produce urticarial signs and symptoms. Let's look at what you can do in a particular CIndUs. So for cold symptomatic dermographism, cholinergic pressure, and solar urticaria, you have your provocation test that you can do in all of them. You can do a threshold test in them. The disease control is all measured by the urticaria control test. Validated quality of life measures have been validated for cold, symptomatic dermographism, and cholinergic urticaria. Disease activity has also been validated in cold, symptomatic dermographism, and cholinergic urticaria. So let's look at the most common symptomatic dermographism, also known as dermographia or dermatographia. They manifest as rapid onset of wheal and flare reactions after skin rubbing or scratching. I wanted to show you these two photos to let you realize that they may manifest differently in dark skin as in light skin person. The provocation test is the simple stroking the skin with a firm object such as a tongue blade, and you will see a red line rapidly followed by a linear itch, wheal, flare response. You can use a dermatographer testing, which allows a threshold testing, or you can do the freak test, which actually is mechanism that you hold perpendicular to the forearm with enough pressure so that the tips are almost invisible. You draw a line across with a single firm stroke, and the positive with all four lines shows severe dermographism, whereas if you only have a wheal in the largest pin, which is 4 millimeters, this is still considered a positive test, but that you probably have a milder grading. The cold urticaria has an incidence of 0.5%. You have higher rates in cold climate countries and is more frequent in women. It can begin at any age, but mostly around the second to the fourth decade of life. So let's hear this patient's story.
The symptoms that I have do prevent me from being outside in activities that I used to like to go do, like hiking, you know, in the snow up in the mountains. We used to go tubing. camping, all of those, even taking a walk outside, I can't do in the cold weather. So I'm kind of limited to staying in the house. Even, taking my dog for a walk, it's very hard going outside. The symptoms that made me go see my doctor after the initial onset was the hives, the burning, anxiety, the depression. It all comes as one. It's not just the rash that comes on. And it's the burning, the depression, the anxiety, a fear, like something's going to happen, I'm going to stop breathing. That's what made me go see the doctor. The disease has affected my overall quality of life, my daily life. I have to plan. I have to make sure that I have my warm clothes on. And I can't get too warm because I have the heat urticaria too. So that's kind of they bang heads. I just have to be careful that, if I'm going to go outside, I have to hurry and get to the car, make sure it's warmed in the cold air. I can't do outside activities with family. Like I said, it's come to a complete stop. My kids are in their early 30s. We love going to the mountains. It affects my job. I'm a massage therapist. I have this the symptoms coming on and I'm in the middle of a massage. I can't leave my patients. So it's hard. It's hard to deal with. I want my body to function, and I don't want to have to leave Colorado to go live in a warm climate somewhere because I don't want to leave my kids. This is my life here.
So you can see our patient story of cold urticaria, which has the quality of life that is really, the symptoms are terrible and affects her quality of life. So with cold urticaria, you have these pruritic hives that are confined to cold exposed areas. However, you can have systemic reactions that are mostly associated with systemic cold exposure. They can have generalized urticaria, headache, dyspnea, hypotension, and fatalities. And this is what she's so deadly afraid of, is that her throat will close, or she can have anaphylaxis from the cold exposures. Symptoms generally occur after the skin is rewarmed, after exposure and then the rewarming of the skin. There are common activities that do this: outdoor skin exposure to cold, hand swelling when holding cold objects, lip laryngeal symptoms when ingesting cold foods and beverages, and sometimes if it's so severe, it's just doing the everyday things, just as like what she's doing in her job. So there are provocation tests, as I said, that you can do with ice cube. You can put your ice cube in a plastic bag, put it in the volar arm for 5 minutes, and assess your will and flare after 10 minutes. Then you can do your threshold testing. Your temperature threshold is the highest temperature or the warmest temperature to induce a positive test. It can be assessed with a temp test, but an ice cube test cannot give you a threshold. You can help the patient to avoid risky situations in their daily lives, depending on this temperature threshold. It's useful for assessing your disease activity as well as the efficacy of your therapy. This is how the temp test looks like. You can test all temperatures between 4 degrees and body temperature. As you can see that the 4 degrees snowball fighting can expose you to this temperature, whereas swimming in lake water is about 16 degrees centigrade. So more or less, you can let the patient know what activities will expose this patient depending on the threshold that they have. There are other provocation tests to differentiate urticaria types. Your cholinergic urticaria, the test could be a stationary bike or treadmill. You exercise them to the point of sweating and up to 15 minutes beyond or the onset of symptoms, or you can have a hot water immersion. Solar urticaria photo testing to various wavelengths of light is how you test it. That includes UVA, UVB, visible wavelengths. The exposure is done on the buttocks. You read immediately after light exposure. Usually rapid urticarial response within 10 minutes is seen. If initial test is negative after 1 to 3 minutes, repeat in originally affected skin. If all is negative, then bring out the patient to the direct sunlight. Photosensitivity to visible lights can be tested by using a slide projector at a distance of 10 centimeters. For the late pressure urticaria and angioedema, you can test the patient by putting a 15-pound weight over the shoulder for about 10 to 15 minutes. A positive test will be deep painful wheals 2 to 12 hours later. It usually the peak is about 4 to 6.5 hours. You can use a calibrated dermatographer or a weighted metal rods. But in the office, you can probably use what you call an at-home challenge 6 hours before their outpatient evaluation. Have them suspend a bag of about 15 pounds on a 3-centimeter shoulder strap, either in the thigh or in the forearm, for 10 to 15 minutes, and then schedule their follow-up appointment in about 4 to 6 hours in your office to observe for urticaria and angioedema. So now I would like to call on Dr. Maurer so then we can start to discuss about traditional and non-traditional treatment options for CIndU and CSU. Dr. Maurer?
Well, thank you. Thank you very much. Let's start with what we have and then go to what we would like to have and what's currently under development. And good guidance to turn to is that provided by the international guideline that was just redone, updated and revised. I recommend that you read this paper. This guideline makes it very clear the goal of our treatment, and that's true for chronic spontaneous urticaria and chronic inducible urticaria, is to treat our patients until their disease is gone. And this means we want to achieve two things. First, to provide our patients with protection from the signs and symptoms so that they become free of them, have complete control and lead a normal life. And to do that, as long as it takes for the disease in that patient to go into spontaneous remission. Now, I want to ask you a question. I'm sure that you know that antihistamines and also omalizumab are part of the guideline recommended treatment algorithm. Now, in which patient scenario would you decide to initiate or refer to OMA treatment? Is it non-responders to FDA-approved doses of an antihistamine? Is it non-response to a double FDA-approved dose of an antihistamine? Or do you go to quadruple FDA-approved dose of an antihistamine before you initiate omalizumab treatment, or are you unsure? We will come back to this question and your answers in a bit, but let me review for you what the guideline says. The guideline has 3 steps. It's a step-up algorithm where we start with a second-generation antihistamine, a modern one, non-sedating one in all patients. And we use the standard dose here. And we know that many patients do not respond adequately to a standard dosed antihistamine, which is why we recommend that after 2 to 4 weeks, we updose and go up to 4 times the standard dose. And again, give this higher dose antihistamine treatment some weeks, not longer than 4 weeks, to see if it works. And if it doesn't work, we go to a second-line treatment. And currently, the only second-line recommended and licensed treatment is omalizumab at standard dose, 300 milligrams subcutaneously every 4 weeks. We give this some time to see how well it works. And if we do not achieve adequate control, then we use higher than standard doses of omalizumab before, after 6 months of trying and it not working at that time, going to cyclosporin. These are the 3 treatment options that are recommended today. We will see a little bit later that many more treatment options are currently under development and will hopefully come to us soon. But that's what we have, and that's what we use. And it is critical that we use these treatment options based on the level of control that our patients have. Now, you already know the urticaria control test and its cutoff of 12 points, where everything that's below 12 points reflects uncontrolled disease, is a call to action to us to step it up, to move to the next step of the guideline algorithm until we reach 12 points minimum. This puts us at well controlled, not perfect, but well controlled, at which point we should try to optimize to really get our patients to 16 points in that control test, which reflects complete response. And that is when we can think about stepping down. So it is critical that patients use this test every 4 weeks and provide us with the information, does their treatment work or not? Now, there are some predictors when it comes to treatment, response to antihistamine, response to omalizumab. The treatment algorithm is the same for all patients, but knowing about the underlying cause and how these different causes are linked to different responses helps us to manage expectations. We know that there are two major causes of chronic spontaneous urticaria. Both are autoantibody based, but the far more common autoallergic type of chronic spontaneous urticaria comes with IgE autoantibodies to autoallergens. The more severe but less frequent autoimmune chronic spontaneous urticaria comes with IgG antibodies that are directed to the high affinity IgE receptor or IgE on mast cells. All of these autoantibodies activate mast cells. That's the key driver of the development of wheals, hives, itch, and angioedema. But what is the difference between these different mechanisms? If you focus on the left, autoimmune chronic spontaneous urticaria, you see that this type of chronic urticaria comes with a poor response, a lower response rate to omalizumab, a slow response. So step 1 and step 2 of the treatment algorithm do not work as well and or as fast in these patients. On the flip side, these patients show higher rates of response to cyclosporin. The autoallergic chronic spontaneous urticaria patients, well, they have a quick response to omalizumab, and most of these patients respond. So it does make a difference for patients why they have their chronic spontaneous urticaria, but you would still try omalizumab when antihistamines fail in all of them. We know this difference of response because there is a standalone test, the basophil activation test, that when positive shows us that there is autoimmune chronic spontaneous urticaria. And you can see that it takes those who do respond much longer when there are basophil activation test positive as compared to negative. On the other side, having high IgE, a marker of autoallergic urticaria, is good for patients when it comes to their chance of responding to omalizumab, where 4 out of 5 complete responders to this treatment have elevated levels of IgE. So what should make you wonder about how omalizumab is going to work is a low IgE, IgG anti-TPO markers of autoimmune chronic spontaneous urticaria. Let's look how all of this works out in real life and listen to a patient and her experience with the different treatments that were used in her chronic spontaneous urticaria.
So we did the elimination diets. None of that made any difference. We looked into detergents, perfumes, things like that. None of that was the issue. So then it was, okay, we're going to throw her on H1 blockers and H2 blockers, and we'll see what happens. And it got so bad within just those few months. The angioedema got really bad. So I had a lot of swelling, hands, feet, even like my lips. That's where he kind of started throwing up his hands. I was still only 16 years old. So my mom's like, all right, we're taking you to the pediatrician. And he just kind of personally was like, hey, these are the things that kind of worked for me. Let's try it for you. So it made me feel better, like I wasn't the only one. But still, the corticosteroid was really the only thing that did anything. And I was on that a really, really long time and had a lot of problems because of that. So, but it was the only thing that worked at the time. I was on the corticosteroid for about 9 months, which is a long time. And they weren't like tiny dosages. Like I was on enough to completely control the hives. Because without it, I was itching till I bled. I was head to toe. So the corticosteroid put on at least, I'd say 20 pounds of water weight pretty quick. And that was really tough. But then it did get worse. As we tapered off of it, I started to get daily migraines and they were bad. And I was a kid. I'd never had, even a headache. I really didn't have headaches. I had migraines every day and it was bad. Of course, once we got off the prednisone, we were still on all the other oral stuff, all the H1, H2 blockers and some random stuff, all oral medications. And once it seemed like once I was off the prednisone and the pseudo tumor had been in control, I wasn't breaking out, but everyone was afraid to take me off of the H1, H2 blockers.
Yeah. Unfortunately, this is not an exception. This is a very typical story. And you heard two things. A whole bunch of antihistamines, H1, H2 were used. We don't do that. We don't combine. We don't go from one to another. If one antihistamine does not work, there's a very low chance that a second one will. Then it is time, after you maxed out the dose, to go to omalizumab. And steroids, cortisone, have no place in the long-term treatment of chronic spontaneous urticaria. They do more harm than they do good. So please follow the guideline recommended algorithm, step up the treatment as needed based on the urticaria control test. And this graph shows you what has already been said, that only about 20% of patients have their disease under control. And this is really based on measurements with the urticaria control test, where we see on the left total patients, 79 do not have a UCT score of 12 or more, which they should have in order to have controlled disease. And it really doesn't matter for how long they've had their disease, for less than a year or 2 to 3 years or more than 8 years, it's still a very high percentage, red, UCT of less than 12. We need to do better. And for this, we need two things. We need to make better use of what we already have, good antihistamines in higher than standard doses if needed, omalizumab, but we also need better treatment options. And we need to convince our patients that in order for us to best help them, we need to know where they stand. We need their UCT. And there's this fabulous new app that we now have globally, Cruise, Chronic Urticaria Self-Evaluation app. Download it right now with this QR code and provide your patients with the information that they can document their disease, including their urticaria control with the UCT by using this app. Of course, there are other apps as well, but this one is ideal from my point of view because patients can also send their UCT score directly to me or to their treating physicians. When we have this information, then we can help patients better, and patients see by the use of the app where they stand. Is there still room for improvement? Do I need to do things differently? They can also take pictures. So please use this app in combination with good treatment to achieve the best treatment outcomes. I want to switch gears a little because part of the reason why we still have patients with uncontrolled disease is because the current treatment options do not help everyone. And this is why we need novel, better, new treatments for chronic urticaria, chronic spontaneous, and chronic inducible urticaria. Today, we only have a few, and we have a high need, especially in autoimmune chronic spontaneous urticaria patients. So we need better targeted treatments, especially for those with underlying autoimmunity. Let's see what we know about chronic urticaria that could help us to develop better treatment options. And you see the mast cell as the key cellular driver in the skin of our urticaria patients as the major target with its receptors and its mediators. You also see basophils and eosinophils that we want to target, and B cells and T cells, which of course produce the autoimmunity and the immune profile that drives mast cells to be so pro-inflammatory in chronic urticaria. So when it comes to targets of emerging therapy, is it exactly these receptors that we want to shut down? It's exactly these mediators that we want to antagonize and make use of some inhibitory receptor that work to silence mast cells. These are novel treatment options currently under development. So let's look at them with a little bit more strategy. We want to shut down mast cells because that will shut down chronic urticaria. And we can do this by 4 different approaches. We can inhibit mediators that come out of mast cells. We can inhibit activation pathways that get mast cells to release these mediators. We can silence mast cells, and we can even deplete them, take them out completely. So let's go step by step and look at these emerging therapies. What mediators would we like to inhibit, and what programs are currently under development to do so? Interleukin 4 and 13 for sure, 5 as well, but also 17 and 23 in a subset of autoimmune chronic spontaneous urticaria patients. And it would be nice to not only be able to block the H1 and H2 receptor, but also the H4 receptor. Let's start with IL-4/13. These are type 2, Th2 cytokines that drive the pro-inflammatory milieu that is characteristic of chronic spontaneous urticaria. We already know that patients with chronic spontaneous urticaria have IL-4 and 5/13 positive cells in their skin, that levels of IL-4 are up in urticaria, that dupilumab can work. And since 2021, we have positive results from a controlled trial in dupilumab, with dupilumab in chronic spontaneous urticaria. So high hope that dupilumab will be a future treatment option. As you can see here from this trial, a significant and marked reduction on the left in itch intensity, on the right in urticaria activity as measured with the urticaria activity score. This is what we need. Drugs that work, and here measured with the gold standard of assessing disease activity and response to treatment. Now, what is good about dupilumab is that it works in both patients with normal and elevated IgE levels. Sort of an all-comer treatment, if you want, at least when it comes to baseline IgE levels. And you can see here that it really, across all the different outcomes that we looked at, both itch and urticaria activity score, total, but also hive score, in patients with or without allergic comorbidity, it provides a good response, statistically significant response as compared to placebo. Another one that we would love to explore more is IL-5. Why? Because it is involved in the crosstalk between mast cells and eosinophils. 3 drugs have been shown in case reports and small trials to work: benralizumab, mepolizumab, and reslizumab, all targeting IL-5 or its receptor, with a reduction in disease activity here shown for benralizumab. So we're looking forward to the outcomes of anti-IL-5 treatments in chronic spontaneous urticaria. Now, IL-17 is interesting, no, because it doesn't fit with the others where we think of type 2 inflammation, IgE, itch. Here we are talking about a, well, type 1, type 17 cytokine that is linked to autoimmunity. A small trial has shown that it works in patient. Secukinumab is an anti-IL-17 and also works in patients who do not respond to omalizumab. So it may be the autoimmune chronic spontaneous urticaria patients who better respond to secukinumab. How about inhibition of activation? We know, of course, from omalizumab that the IgE receptor is important. There are programs for TSLP, and we're looking at this complement receptor, C5a receptor, and MAS-related G protein coupled receptor X2, and downstream signal transduction pathways of receptors that activate mast cells, such as BTK, YAC, and STAT. Let's briefly summarize TSLP, which can activate mast cells, come from mast cells. It's an alarmin. And we have seen from previous studies that levels of TSLP are elevated in the lesions of chronic spontaneous urticaria. And this antibody, tezepelumab, it targets TSLP, and the clinical trial is currently ongoing. We're looking forward to receiving the results soon to see what's going on. Now, complement is especially interesting in the context of autoimmune chronic spontaneous urticaria. Why? Because these autoantibodies that activate mast cells via the IgE receptor are complement activating autoantibodies. And they make C5a, which is an anaphylotoxin. In other words, a very strong mast cell degranulator. Complement can also be activated by other pathways that relate to non-autoimmune chronic spontaneous urticaria, but the highest hopes are for inhibition of complement in autoimmune chronic spontaneous urticaria. And then there's a very promising new treatment target, and that's Bruton's tyrosine kinase. Why do we have such high hopes in targeting BTK? Well, BTK sits downstream of the IgE receptor. So no matter how the IgE receptor is used to activate mast cells, it needs to go through BTK to translate into degranulation. But it also sits downstream of the B cell receptor. So it is important for autoantibody production. So both of these things are critical in chronic spontaneous urticaria, where mast cells are the key drivers in the skin, and B cells, plasma cells, are the producers of the autoantibodies that activate mast cells. And this study with fenebrutinib, a BTK inhibitor, shows black is placebo, colored lines are different doses of fenebrutinib. It works fast, sustained response over these 8 weeks of treatment. And this is not only so for fenebrutinib, but also for remibrutinib, where you can see all the blue lines are remibrutinib doses compared to the gray line, a fast reduction in disease activity, sustained response over the course of treatment. So this is, because there are several BTK inhibitor programs, a very promising approach. And finally, and this is very novel, we can silence mast cells. How do we do that? We use inhibitory receptors. Now, there's not many inhibitory receptors, but Siglec-8 is one of them. And when you engage Siglec-8, and you can do this with an antibody called lirentelimab, then this produces an inhibitory signal that acts on activating receptors. And a study that was published in the last year showed that when you treat patients with chronic spontaneous urticaria, and this is true for both patients who are naive to omalizumab or who had failed omalizumab, you reduce disease activity with lirentelimab by silencing mast cells. Now, the most radical, and this is the last approach we will discuss today, is to take out mast cells. No mast cells, no urticaria. You need mast cells to produce the hives and the angioedema. Now, how do you kill mast cells? Mast cells have KIT. It's a receptor that is needed to detect SCF, stem cell factor. And as long as mast cells can see the SCF via KIT, they stay alive, produce a little bit of tryptase. We can measure that and see that they're alive. But when we block KIT so that it no longer can bind SCF, mast cells die. They go into apoptosis, stop producing tryptase, and vanish. Now, when we look at two different diseases, cold urticaria here and symptomatic dermographism in the next slide, then we can see that one shot of this mast cell depleting antibody, it's called barzolvolimab, reduces disease activity very quickly. It makes patients free of signs and symptoms. Also true for symptomatic dermographism, where virtually all patients become complete responders and no longer respond to cold by producing wheals or respond to scratching of their skin by producing wheals. So let me summarize. We have a number of very promising emerging treatment options for chronic urticaria. And finally, also treatment options for chronic inducible urticaria, including cold urticaria. Mind you, omalizumab is recommended for the treatment of all forms of chronic urticaria, but licensed only for chronic spontaneous urticaria. Now, what do these treatments have in common? They all target mast cells, their mediators, activating pathways, or cells that are recruited by mast cells and their activation. What is exciting is that we will move to an endotype-specific treatment in some patients. Today, autoimmune chronic spontaneous urticaria patients have the short end of the stick. There's no question about it. Omalizumab can work, but it works better in those who do not have autoimmune chronic spontaneous urticaria. We will be able to target that endotype better in the future, and we will hopefully also have more all-comer treatments that work across the board, no matter what the underlying cause is. Now, what's different between these different emerging treatments is that they're in different stages of development. Dupilumab, for example, is very far advanced, so are some BTK inhibitors. Others, like mast cell depleters or mast cell silencers, will take a little longer to complete the development program and come to us as a licensed treatment options. What we can do today is guide patients to these studies. It's very important. It's fairly novel that we can offer studies to our patients with chronic urticaria. So let's make them aware that these studies exist, where study centers are, to help to complete these programs. That brings me back to two major points that I want to make. We talked a lot about the urticaria control test. Where can you get it? I leave this here for you. 3 options. Use your QR code scanner right now to get this on your phone and to provide your patients with one of these sources for the UCT. The other one is the answer to your, or the information on your answers to the questions, when do you use omalizumab? And the most common answer is actually very much in line with the guideline. And that is in case of non-response to a 4 times FDA-approved dose of an antihistamine. Again, please follow that algorithm until we have more drugs to enter the algorithm. Non-sedating antihistamine, go up in the dose if it doesn't work. Then omalizumab, go up in the dose that doesn't work. And base the whole thing, the whole step-up approach on your patient's UCT values. And that brings us, thank you very much for staying on until this part of the program, to our question and answer session. We've already received quite a bit. I'm looking at the bottom here. So Luz, stand by. We will go to these questions, but please, if you have questions that you haven't asked as of now, please do so. We will attempt to answer all of them. Luz, are you ready for some of these questions?
Yes, I am.
Super. Okay, look, we have a very interesting one here. The first one is there a way to identify those who will and will not respond to omalizumab? Look, I'll take this one, Luz, because I talked about this when I talked about the predictors of response. These are not black and white predictors, no, but they give us a good idea. They come with a different risk profile. Low IgE is a high risk of non-response. Elevated IgG and TTPO, elevated risk. So anything that points to autoimmune chronic spontaneous urticaria is a risk factor for non-response to omalizumab, whereas high IgE levels are something to be happy about as a chronic spontaneous urticaria patient, because it increases your chance of responding to omalizumab. But we still use OMA in all patients. We're just more aware that these predictors of autoimmunity could give us non-responder patients. Second question is, and please, Luz, chime in and let us benefit from your experience. How fast do you recommend escalating the H1 dose? Maybe I'll start and then you can say if you do the same thing. Look, I'm not a very patient man. So if I see that the antihistamine doesn't work at standard dose, I go right up to 4 times the standard dose. And I do this as soon as after 2 weeks of treatment. How about you?
Yes, I do the same, but what I do is I allow the patients to do it themselves without having to come in. So what I would do is if they already failed 1 tablet, I would say go up to 2, because a lot of them are hesitant to go to 4. And in 1 to 2 weeks, if you're not responding, go up to 4 times the recommended dose. So I let them do this, and then I bring them back in the office for 4 to 6 weeks. At that point is where we start the discussion of omalizumab, and that if 4 times doesn't work, then 10 antihistamines isn't going to work either, and you're just delaying the need for the use of medication that is very effective. The question that could be related to the question number one that you have, Marcus, is how long do we wait? When do we say that omalizumab has actually failed in terms of the treatment? Once you're on omalizumab, usually about 4 to 6 months is when I start to step up or say it doesn't work, and maybe we can go on to even a higher dose.
Yeah, I do the same thing, Luz. That's a very good advice. In patients where I have an autoimmune signature, let's say, I even updose a little bit earlier. And often in these patients, it's enough to do 300 milligrams every 2 weeks for just 3 or 4 times. And then you have a response, and you can start to increase the intervals again. Maybe another tip for you out there, we split the dose. So when we go to 4 times the antihistamine, we give 2 in the mornings, 2 at night. Pharmacologically, it doesn't make a difference, but patients tend to be more compliant with taking 2 in the mornings and 2 at night rather than taking 4 at once. So maybe that's a trick to increase compliance in your patients as well. Brings us to question number 3. How do you define response and incomplete response? That's a very interesting question. For me, complete response is complete response. No more signs and symptoms, complete control, and no more impact on the patient's life. I measure it with the UCT, I've said it often. And look, no more impact on patients' lives also means that they will do things again without being afraid that this will cause them to wheel. They can eat everything they want, they can do sports, they can travel, they can have fun, party, whatever it is that they want to do. Their disease no longer stops them from doing it. This is when you've reached complete response, and this is why we also recommend to use the UCT to establish control, but also to assess disease activity and the impact by quality of life instruments, very simple ones, all of them. In CRUISE, the Chronic Urticaria Self-Evaluation app. So you have in this app all that you need to establish response. It will even visualize the response for patients with a little smiley scheme. So for me, I push until I have complete control, no more disease activity, and no more impact of the disease. If patients are happy with a little less, then that's fine for me. But I start my conversation with patients with, I know what you have, I can help you, and I will not stop to try until we have this completely under control.
Yeah. It's interesting. The question actually, I think one of the questions is, can your patient be well clinically, and yet they're still suffering the burden of the disease? And this is the question of the scale as against a quality of life. And there are actually 2 measures, and the answer is yes, that it does happen, because the quality of life as against the burden of the disease may lag in terms of treatment. And it's, in fact, sometimes the treatment itself can be a burden to the patient, affecting their quality of life as well. So the answer to that question is yes.
Oh, absolutely. We didn't talk much about angioedema. We should talk a little bit more about angioedema, because it occurs in up to 70% of patients with chronic spontaneous urticaria. And the problem with angioedema is the unpredictability and the fear of angioedema. Now, some patients have angioedema every couple of weeks or even every couple of months. It takes time for them to realize, when they start a new treatment, that now they are protected from that now they no longer have to fear waking up with a swollen lip or a swollen eye. And this is exactly what you say. We can, with our treatments, bring down disease activity, but often quality of life, which includes fear, anxiety, also being sad and depressed, even like we heard from the patient. This takes a little bit longer until patients really have confidence in the treatment and that it works. Luz, I have a question here on cold urticaria. What steps do you recommend for a patient with CIndU who has cold urticaria? Do you want to summarize that real quick again?
Well, the treatment obviously for patients with any CIndU is to identify what the triggers are. And sometimes they have single, sometimes they have multiple triggers to their urticaria. The treatment is the same. Antihistamines initially, and then higher doses of antihistamines, and then omalizumab, although not approved for CIndU, we know is effective. There is, interestingly, for cold urticaria, a process of what we call desensitization, but this is a process that is a little bit it's not invasive, but it takes quite a while to do. You can have risk of anaphylaxis, and once you have a state of what you call desensitization, is that the patient has to keep on doing the cold immersion 2 to 3 times a week to maintain the desensitization.
Yep.
Anything you want to add, Marcus?
We haven't done it in a long time, Luz. No, this is something I remember doing in the 80s or early 90s, but I haven't done desensitization in many years. Look, what tests do you perform to identify the causes of CIndU? Well, wouldn't it be nice if we knew the causes of CIndU? So the short answer is none. I know that at many Urticaria Centers of Reference and Excellence, there are very active research programs to identify the underlying causes of chronic inducible urticaria. And some of the preliminary results point to autoallergy as a driver, similar to chronic spontaneous urticaria, but there are no tests for routine clinical practice to look at the underlying causes in chronic inducible urticaria, including cold urticaria. We're moving to the end of our program here, but maybe we have time for one more question, and this is a very interesting one. Are there different physiological pathways depending on the triggers of CIndU? And the answer to is there must be, because you cannot produce wheals in a cold urticaria patient by scratching, whereas you cannot produce a wheal in a symptomatic dermographism patients by cold. So clearly these triggers that act on the skin produce signature proteins that then act as drivers of specific mast cell activation, CIndU specific mast cell activation, and that must make for a difference in pathophysiology. Now, it could be that what happens is that these triggers all produce different sets of proteins that are autoallergens. So it could all be autoallergy, but yet the autoallergens must be different, the autoallergens in cold urticaria from the ones in symptomatic dermographism, from the ones in pressure urticaria, aquagenic and solar urticaria, and so on.
Yeah, I guess we do have a lot to learn still. We need to look at triggers. We need to do a more specific treatment as well.
Absolutely, and we do. The Global Network of Urticaria Centers of Reference and Excellence is working together to produce more information. We work with our partners in industry. So if you're interested in what the UK network does, or if you want to join it, please check it out at our website.
All right, this gets us to the end of our program, and I would like to thank Dr. Maurer, thank our audience for the great questions. I would like to thank Sanofi and Regeneron Pharmaceuticals for the support of this very important educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. Please visit immunologylive.com to view today's session along with the other sessions on demand. My name is Dr. Luz Fonasher, and together with Dr. Maurer, we would like to thank you for joining us in today's activity.